Hello everyone. In this section, we are going to see about endocrine assessment. I am Brinda Ronika, working as a tutor in Tribhulam College of Nursing. Objectives of today's section is define key endocrine terminologies related to common disorders, discuss the components of patient history relevant to endocrine disorders including medical, surgical, lifestyle and family history, demonstrate a systemic head-to-toe assessment focusing on signs of endocrine dysfunction. Now, before going into the topic, we'll see some of the terminologies which is related to endocrine assessment. First one is acanthosis nigricans, which is a dark velvety discoloration that appears in body folds like the back of the neck and armpits. So you can see this in diabetes mellitus. Next one is acromegaly. So here what happens when the pituitary releases too much growth hormone in adulthood, the person cannot grow taller anymore. So the hands, jaw and facial features enlarge. Then next one is a cretinism. Cretinism is when a baby is born with absent or severely underfunctioning thyroid. The brain and body do not develop properly. This is why we screen every newborn for thyroid function. Next one is exophthalmos. It is a bulging or protruding eyeballs. It is a hallmark for Graves' disease. When you see a patient with eyes that seem to be pushing forward, think about thyroid immediately. And the next one is diplopia. It just means double vision. It can be a feature of hyperthyroidism. Next one is a gynecomastia. It is an enlargement of male breast tissue. So it signals a hormonal imbalances. Next one is hirsutism. So hirsutism means it is an excessive dark horse hair growth in women in a male pattern on the face, chest and back. So it tells you there is an androgen excess. You can see this in Cushing syndrome, PCOS and adrenal disorders. Next one is koilonychia. So this is already it is spoon-shaped nails. Next one is ankylosis. Ankylosis means the painlessly the nails separate from the nail bud. You can see this in thyrotoxicosis. Next one is goiter. It is nothing but enlargement of thyroid gland. So visibly we can able to see it in the neck. Next one is a myxedema. So it is a severe hypothyroidism where the skin and soft tissue swell with a mucus like substance. So the face looks puffy, movements are slow, speech is slow. In extreme form it is a medical emergency. Next one is a buffalo hump. It is a fat pad that accumulates on the upper back and neck. It is a classic sign of Cushing syndrome. Next one is a striae or stretch marks. The purple or dark pinky striae are a hallmark of Cushing syndrome. Next one is a moon face. It is a round, fully puffy face seen in Cushing due to fat deposition in the cheeks. And the three polys of diabetes also we should know: polyuria, polyphagia and polydipsia. Polyuria means excessive urination, polyphagia means excessive hunger and polydipsia means excessive thirst. Okay, next we'll move into very important part, assessment, and that first one is a subjective data, history. First we have to ask about the present health history. So when you sit with an endocrine patient, remember that they rarely come in with one clear complaint. It is almost always a cluster of symptoms like fatigue, weight changes, menstrual irregularities, weakness, mood changes, and the thing it is, your job is to connect those dots. So ask about onset. Did these symptoms come on suddenly or have they been creeping up gradually over months or years? Most endocrine conditions develop very slowly only. And ask about weight changes. Has the patient gained or lost weight with a clear change in eating habits? Weight loss with increased appetite points to a hyperthyroidism or diabetes. Weight gain, especially around the trunk with thin limbs, point to Cushing or hypothyroidism. For women, always take a detailed menstrual history. Irregular or absent periods can be caused by disorders of the ovaries, pituitary, thyroid, or adrenal gland. All four can affect the menstrual cycle. Also, ask about pregnancy history, a history of delivering large babies over 4 kilograms, and signals gestational diabetes mellitus, which puts the mother at higher risk of developing type 2 diabetes later. Ask about mental sharpness, memory problems, difficulty concentrating, brain fog. These are common in endocrine disorders, and patients often attribute them to stress or aging, but they may actually the sign of hypothyroidism. Ask about libido and sexual function. Decreased libido in both men and women can be hormonal, but in men also ask about impotence and infertility. In diabetic men, specifically ask about retrograde ejaculation. These are real clinical findings that patients often don't volunteer unless you ask directly. And ask about visual changes, blurring or double vision, and also headaches, whether it is present or not, because it is a symptom of growing pituitary lesions. And also bowel patterns, frequent loose stools point to hyperthyroidism or diabetic autonomic neuropathy. Constipation points to hypothyroidism, hypoparathyroidism, and hypopituitarism. In bladder, increased urination can be diabetes mellitus or diabetes insipidus also. Then past health history. In that, medication history is critical. Always ask about steroids, insulin, and thyroid hormone. Long-term steroid use cause elevated blood glucose and bone loss and can produce a picture that looks just like Cushing syndrome, which is called iatrogenic Cushing syndrome, means which caused by medication. And lithium, if they are taking lithium, means it can suppress the thyroid function. And amiodarone, which is commonly used in cardiac patient, it can cause both hyper and hypothyroidism. And also ask about any surgeries involving endocrine glands like thyroidectomy, adrenalectomy, because which completely changes the hormonal pattern. Next one is a family history. Quickly ask about diabetes, thyroid disorders, PCOS, and any genetic syndromes in the family. Mainly type 1 and type 2 diabetes you have to ask. Then next about is a metabolic history. We have to ask about whether patient is having any nervousness, palpitations, sweating, or tremors occurring together. The cluster points to hypothyroidism or rarely to pheochromocytomia, which is a tumor in the adrenal medulla and secrete excess amount of adrenaline. And also we have to ask about heat and cold intolerance, heat tolerance in hypothyroidism, cold tolerance, always cold, needing extra blankets in warm weather, which is a hypothyroidism. Okay, next one is we have to ask about the food, activity, sleep, menstrual, and psychological history. First one is a food. So in that, weight loss and weight gain. Weight loss with increased appetite means hyperthyroidism or diabetes. Weight gain with central obesity, thin limbs, and purple striae means Cushing syndrome. Difficulty in swallowing or neck tightens means the thyroid may be large enough to press on the esophagus. And next one is the activity. Ask about energy levels and how they compare to 6 months ago. Mainly profound fatigue with minimal activity is a hypothyroidism or adrenal insufficiency. If it is a excessive energy and restless means it is a hyperthyroidism. Next, in sleep, polyuria causes the patient to wake up multiple times at night to urinate. In type 1 diabetic on tight glucose control who reports nightmares and waking up sweating, so which is called nocturnal hypoglycemia. And ask male diabetic patients specifically about snoring, because which is a sign of sleep apnea. And in females we have to ask about the menstrual and reproductive history. Irregular cycles always need an endocrine workup, and recurrent miscarriages should prompt a thyroid check. Infertility with irregular periods, and we have to think about the OS. And the last one is a psychological history. And depression in apathy can be a hypothyroidism. Anxiety, agitation, and restlessness are hypothyroidism. And aggression, irritability point to adrenal disorder. Lethargy and slow speech is a hypothyroidism. Always as a psychological state because hormones directly drive mood and behavior. Okay, so this is about the history. In the next part, we'll see about the physical examination. Thank you.